Hi, so my name's Chantal and this is Megan, and we're
Hi.
both from BHA for Equality. And this is the Health Inequalities charity, and we serve communities who do not identify as white British across the Northwest. So we're both sexual health advisors and leads for inclusion and engagement for our Manchester sexual health team. And this is part of the PASH partnership, who we work with George House Trust and LGBT Foundation. So we'd just like to say welcome and thank you for coming along today to this session on STIs in Black Caribbean communities, where we're looking at breaking down barriers to prevention, testing and partner notification. This project was informed by this presentation is informed by the Black Caribbean project, which was funded by the Manchester City Council as well. So we'll present for 20 minutes and then we'll have space for a discussion for the remaining 10 minutes. If you could put any questions in the Q&A box and any comments and feedback in the chat. Thank you. I'll pass you over to Megan now.
Cool. So we're going to start off with the data which sparked this project and this presentation. So as you can see from the slides and the Public Health England data tables, it's very clear that there is a clear inequality in STI diagnosis, with Black Caribbean individuals bearing the highest amount of STI diagnoses. And I just want to note that there's been some a more recent report, but the data has not really changed that much. So this inequality is persisting. So this is what sparked the project. We then began looking into other research, which began to question why this is the case. And first of all, there wasn't that much research in the field. We also noticed a clear lack of nuance when people were investigating the reasons why people weren't using prevention methods or sharing STI diagnoses, with most papers kind of vaguely pointing at concurrent partnerships or talking about a need to develop confidence in women. So after reading this research, we could see these gaps and knew that as a charity with decades of experience working with Black, Asian and minority ethnic communities, that we were well placed to do some community research around this equality, which we're just going to outline.
So we began the project by holding a small number of focus groups and interviews with people from Black Caribbean heritage in Manchester. And we used semi-structured interview method, and that was to allow space for other related topics to be discussed by participants. So our questionnaire was designed with the intention to reveal those myths and the prevalent misconceptions that are around STIs, the attitudes towards condom use, testing and barriers to sharing the STI diagnoses with partners or accessing sexual health services. So because these are the nuances around all of the topics, that was what was missing from the existing research that Meg was just speaking about earlier. So we used the data from the focus groups and we identified some of the core themes that were running across them. The next slide. So these were awareness, condoms, STI testing, culture around sex, poor experiences at sexual health services, sharing an STI diagnosis, and also stigma. So we've compiled a report and that's structured around these themes, and this is the basis of our presentation today. And then we'll be sharing this with you also further on, so you can have a look at for further reading at the end of the week. We've also produced a video as part of the project, and that was informed by people in the community as well, which addresses those themes as well that you can see on the screen now. We'll be sharing this video with the clinics, hoping that they can share, preview this in the waiting areas and also across social media channels as well.
Okay, so just before we start going into the themes in more depth, why is this relevant to you as healthcare professionals? Why are we doing this workshop? So there's three main reasons. The first one is just about having a deeper understanding of how people within Black Caribbean communities think about STIs, prevention methods, testing and partner notification, so that you can tailor your interventions with the aim of having more impact encouraging behaviour change and good sexual health practice. The second was around the fact that we did encounter several comments and anecdotes about poor experiences people have had at sexual health clinics and general health services. And this project and this workshop is also sitting within a wider context of poor outcomes for Black communities in health in general. So the NHS Race and Health Observatory reported that Black women are 4 times more likely to die in pregnancy and childbirth. Black African and Black Caribbean individuals are 8 times more likely to be subjected to community treatment orders, and BAME communities are times 2 more affected by mortality than white communities. So this is just sitting within the broader problem. And although we are really aware that there are larger systemic forces at play which are causing this, we all have a role to play in ensuring that as professionals we're not contributing to this and we're playing our part in tackling these inequalities. And the third is just about remembering that even though we're seeing hundreds of people in our working lives, unfortunately there is a mistrust of institutions in Black communities, including health institutions. And this could be the first time that someone has access to sexual health service. So if they get a bad experience, it's highly likely that they're going to disengage, and that's not going to help the inequality that we need to be changing. So that's why we're doing this workshop.
So whilst we've drafted this presentation, we've aimed to keep the session like as relevant to your in-life work as possible. So we'll be presenting the main themes from the research and also exploring some of the actionable ways that these themes can be brought up with patients. So in the question section that we have later on, it's an opportunity to discuss together the actionable ways that, you know, can be made in interventions and also in public health messaging. It's also useful for us to have an understanding of like what conversations that you're having during your consultations, and also sharing your practice and your experience with one another.
Okay, so we're going to go straight into the themes now. So the first one was around awareness. So in the focus groups, we found there was a general basic awareness of STIs and prevention methods, but there were some key recurrent misconceptions around transmission, risk and prevention that kept coming up. So the first one was around the use of the words clean and dirty when referring to STI testing or having an STI. For example, one person stated that they were clean, but a partner was dirty because they had an STI. At times, this then became a larger misconception around prevention, as some referenced cleaning as a type of prevention method. So someone said, my friend says she doesn't use a condom, she just has a deep clean. The use of this language is also contributing to stigma around having an STI, which is then feeding into unwillingness, sharing diagnoses or discussing STIs with partners. The second key thing was around what counts as sex and what is a risk. So there were some misconceptions around this, mostly about thinking of sex only in terms of penis and vagina, heterosexual vaginal sex. So a participant talked about how she was unaware that while she was having sex with another woman, she didn't know she was at risk until she was at a clinic when this had to be cleared up by a clinician, which is on the slide. Our recommendations around this of how we can change our practice around this is challenging language when service users use the word clean. So asking what do they mean by the word clean, breaking the stigma by explaining that STIs don't make you dirty and that they are just like any other infection. Also not assuming heterosexual sex, so covering a range of sexual practices when discussing risk, oral, scissoring, topping, bottoming, sex toys, etc., to kind of bring that home to people. And also clearly defining what sex is when you're having the discussion and when you're asking those questions, as they may not count some things as sex if it doesn't fit into their penis and vagina definition.
So in all of the focus groups, there was at least a basic awareness that condoms should be used for protection against STIs. but not all participants made it, all the participants made it clear about the frustrations at being told to wear a condom, because it wasn't as easy to carry this out in real life. So we've had people in the focus groups comment and say that they don't wear condoms, no one does. There's also discussion around the realities of discussing condom use. So a lot of people were saying it's awkward to bring up, there's never the right time, or they didn't like it, or maybe someone just didn't have a condom with them. So for example, someone described as well, if there was that conversation, if it did happen, it's usually reduced, and that's because it's rushed. So it would just be a case of, have you got a condom? And that would be it. A big barrier is also that it's not pleasurable using the condoms as well. So in our campaign, we responded to this by following the condom advice with ways to make it more pleasurable and how it can be integrated into fulfilling sex. So you can see on the slide here, this is one of the examples of one of the posts that we used during the campaign. And this is also something that can be suggested by you as health professionals as well when condoms are mentioned during consultation. So some of the recommendations that we thought of today are, when you are in the room with a patient, is to suggest the different types of condoms. So for example, ribbed and dotted, air thin, speaking about the correct size, maybe something that's got a cooling or a tingling effect, and that could then increase the pleasure for both people. Also talking about using lubes or gel charge as well, which can enhance the pleasure. We spoke about incorporating it into sex, so you could talk about, you know, the partner could be putting the condom on, and also this is whilst, you know, using touch or kissing at the same time. Carrying condoms, making sure that, you know, they're aware that that's an important thing, that you're responsible for carrying condoms for yourself at all times as well. We felt it'd be important as well to reiterate to the individual about conditional consent. So we have conversations around consent and why that's important, also letting them know that there can be a condition on that. So for example, you will have sex, sorry, I will only have sex with you if we do use a condom, and that's completely fine to be having a conversation around that. And also opening up the conversation. So if a patient mentions that them or the partner doesn't want to use the condom, asking them why, and then this could then be an opportunity to talk about pleasure, the size and type of condom, or even, you know, doing a condom demonstration to make sure that they know how to put on a condom correctly.
Okay, the next one was around STI testing. So here there was a general consensus that testing and discussing STIs before sex is probably something they should be doing, but just that these conversations weren't happening, a bit like what we were talking about with condoms. So one woman in a focus group declared that she had discussed it before first having sex with her now husband, to impressed and stunned silence from the rest of the focus group. So she said, I'm straight up, made sure he knew I'm not just going to have a bit of holiday fun, made sure we were both clean, but again, note the use of the word clean there. And this then opened up a wider conversation within the focus group where they were talking about their struggles with bringing up that conversation. So a lot of people were talking about it was about the timing. So either they wouldn't feel comfortable at all bringing it up, or that they would only feel comfortable later on in the relationship and not before sex, or not at the very beginning, which is obviously the most ideal time when we talk about risk. Other people spoke about why there was this fear, and some of it was about a fear of how their partner might react and how their partner might think it meant they were cheating, or it could cause an argument. Other barriers were it's not sexy, not expecting to go there, and also a lack of awareness around a risk again, and like when you need to test and when you need to discuss testing. So someone said, I did it in the bum, so won't catch it. So some stuff around if you're only doing oral or only doing anal, then you don't need to worry about it, which is not the case. But there is stuff we can do to address this. So providing real life conversation starters in the consultation when you're discussing this with them, so that they can then take that home and use that themselves. So stuff like They could say, I haven't tested since X date, shall we book or order one online? Asking their partner when was the last time they did a test. After you've tested someone, encouraging them to go back and say, I went to get an STI test today, I think you can order one online if you want to do one. Maybe giving them some tips around how to approach the discussion. So setting, timing, not bringing it up when your partner's in a bad mood or stressed, ways it can be made lighthearted, and also just prying a bit. So asking what is actually worrying them about telling their partner, so that you can challenge those and talk them through how to deal with reactions they might be worried about. So they might be worried about anger or shame or rejection from the partner, which are all things that you can support them through.
So it was also clear that sharing the STI diagnosis, that was extremely difficult in a socio-specific way for the Black Caribbean participants in Manchester. So whilst we understand that it can be difficult for anyone to share a diagnosis because there's that taboo around the sex, because Black Caribbean communities are small in Manchester, it can make it like much more daunting. So we've had someone who actually commented saying, as you can see on the screen, that every Caribbean in Manchester knows everyone, and how Manchester is a small place. So it makes reference to how it will be weird because you've got, you know, your family members like your sister and your mum. The close-knitness, it's then compounded by specific stigmas which exist within Black Caribbean communities around STIs and sex as well. So several responses reference the connections and the stigma which was attached to sharing diagnosis with partners. Some people were saying, no way, as a woman, they'd definitely not share that diagnosis. Some people said about stigma, how they didn't want to be attached to it and that would stain them. And there was also a willingness to share their diagnosis with a current partner, rather than sharing that with, you know, other partners as well, as they were in a relationship and felt that they were more comfortable in doing so. One person had a logical point of prospect in the continuation of reinfection. So she stated, I would happily share, because if I get treated and then I don't get treated, sorry, if I get treated and they don't get treated, then I'm going to get it again unless we start using condoms. So that was around like just making sure that this person could then, you know, make sure that the treatment was passed for her and her partner, and then she wouldn't continue to get infected again. There's also a narrative around blaming, and someone mentioned how men like to blame and that the blame usually falls on the woman as well. So some recommendations that we thought of around sharing STI diagnosis with a partner is that when you are dealing with a positive STI result, then just to reiterate to the individual that, you know, although there's a need to find the contact, it's not about a blame, it's about making sure that everyone gets the treatment. Also letting them know that STIs, it doesn't make you dirty having that diagnosis, and also it's not about, you know, it's their fault or it's my fault, and also encouraging them that there's no need to moralize. It's important as well to communicate to the person that as a practitioner, healthcare practitioner, that you can contact the partner from the sexual health clinic, and that obviously gives them the choice, and also, you know, makes them know that they're supported if they did not want to share, if they did not want to notify their partner themselves. And also it's just worth having an understanding of the wider context as a professional, why someone may be unwilling to share their contacts as well.
Okay, this is the last theme. So this was around poor experiences at sexual health services. So in all the focus groups, there were some criticisms of sexual health services, public health approaches and staff. So one of the worst ones that came up was around a person who said, I had an experience where I was positive and the next thing I knew, I started hearing the news all around the church I go to. So this was a Manchester-based clinician, Greater Manchester, and is obviously a clear breach of confidentiality, but this was in a focus group, this was discussed, and it turned out that this person hadn't reported it, didn't know she could report it, And others in the focus group were also not aware that this is some confidentiality is something that they should be able to expect when accessing a health service, or that they could report it. So much so that one person actually at the end of the focus group said the one thing she wanted to feed back to policymakers, healthcare services, was that there should be penalties if confidence is broken. So there's a clear lack, they don't know that they can report. Others just felt that maybe there was a lack of empathy from some staff, especially when it came to younger people accessing the service. And several people also felt racially targeted or judged in consultations due to discourse around countries of travel residents when it came to HIV or sexual health. So being asked, because those countries are often Black countries, African countries, Caribbean countries, which is why they were feeling racially targeted. In some cases around these comments, though, there was also had led to misinterpretation as well, where an individual had become complacent about their risk of HIV or STI, because this is a quote from them. They ask you, have you been to countries, high-risk countries? And if you haven't been there, then HIV is pretty much impossible. So even if the clinician hadn't actually said it in exactly those words, that is what that person had taken away from the consultation. Other problems were access difficulties, so appointments being online, and also just a fear of being judged. So if they have to go and sit in a waiting room, fear of being seen by other people in their community because there is stigma, which we've gone through. So our recommendations around this would be just improving the reporting and feedback process, making that clearer on the website, so that when on the rare occasions that this kind of thing does happen, that people do feel like they can report it. Because when it isn't reported, it encourages them to disengage from the service. It increases mistrust in institutions, but it also spreads amongst the close-knit community, and it puts other people off as well. Of course, this feedback process could also be positive feedback, and that this is something that's important as well. It's about hearing what's actually working for communities who are facing inequalities. So if there's a better feedback process, then you can tailor your service based on that feedback. Around the countries of travel and residence, being prepared in that consultation to briefly explain why you're asking the question so that they don't feel racially targeted, and being able to explain prevalence and how that works. And finally, just understanding, especially with younger people or anyone from Black Caribbean demographic, that they're facing this stigma, these barriers that we've gone through. This could be the first time they've accessed the service. It can be intimidating, stressful, and just being aware of that. So that was the last theme, and it's the end of the main talking part of the workshop.